right. So I'm going to briefly introduce us. I am Emily Isaacs. I'm a clinical implementation manager with Maximus. I've been with Maximus for almost 8 years. I will hit 8 years in January. But prior to that, I have over a decade of direct care experience. So I have worked in outpatient settings, intensive outpatient. I've done school-based therapy. I've worked with day treatment, and I've worked as a clinical manager for a PRTF. So bringing lots of that direct care experience to the table before joining Maximus. Since I've been with Maximus, I have worked as a quality coordinator. I have worked managing some of our statewide assessment projects. But over the last couple of years, I have really found a passion for implementations. I know implementation is a big word that I've heard a lot this week, and I really love them. I think our keynote yesterday morning mentioned something about people that are excited about policy and data, and I'm one of those people, weirdly enough. It's really become a passion of mine. So where we're relevant to the TCOM world, and especially in my role, I've actually implemented 5 projects over the last 3 years that use TCOM assessment tools. So I will very briefly share my story of my first implementation. They mentioned fast and furious yesterday. My first one was 2.5 months implementation. I was in my 3rd trimester of being pregnant with my daughter. So we went live with that first project October 1st of 2019. My daughter was born October 13th. So I like to say basically both of my babies were born about the same time. So I really had the pleasure of working with some representatives from TCOM. I see April. I definitely want to give her a thank you. We recognize that as Maximus, we are not maybe the type of company that fits the typical mold of someone that would work with TCOM assessment tools. We do represent a company. We're not representing a state or university or a community mental health center. And I just really want to thank April for her patience and graciousness and willingness to share knowledge as we have navigated this world. So, Natalie, I'm going to have you introduce yourself.
Hi. So my name is Natalie Stepp. I'm a senior program manager on behalf of Maximus. So I oversee 2 contracts, specifically North Dakota and Michigan, where we utilize the CANs to make level of care QRTP determinations. So prior to coming on with Maximus, I have about 12 years of residential direct care experience with a variety of settings. And so I'm going to hand it over to Chelsea.
To stand. Hi, everybody. Actually, I'll pull it for Christy. But, my name is Chelsea McCracking. I'm a program manager with Maximus. Actually, got a promotion right before I came for the conference, so fun times. I am a licensed clinical social worker. Like everybody said, before coming to Maximus, I worked from starting out in foster care, in home services, in residential, and then I also worked for a managed care organization. Actually worked with Emily in a PRTF, and that is how I ended up with Maximus, because she talked about the great work they were doing with QRTP and assessing for kids in residential, and they really, wanted to bring like-minded minds on. So came to Maximus. I've been here for a little over a year, and I currently work with the state of New Hampshire. I'm completing comprehensive assessments for treatment, which of course encompasses QRTP levels of care. So I will hand it over to Christy.
Hi, everybody. I'm Christy Keefer. I have a PhD in education. So I came from the school setting. I was a teacher, high school teacher, and 1 year of middle school for about 20 years. And I started with Maximus about a year ago. And I have this very interesting relationship. I know it says now that I'm the manager of knowledge management. So when I came on, I was actually an assistant program manager. I was helping with New Hampshire CAT and Indiana QRTP, and I was helping with their policies and procedures and understanding the process. But I also have some knowledge about kids and adolescents and what it is they do and don't do. And so that's been a really interesting area for me, and I've heard a lot about how education isn't at the table, and kids spend about 8 hours a day or more with educators, and I hope that we're getting more and more educators at the table because I think that's really important. Our next slide. Oh,
it went the wrong way.
Went the wrong way. Here's our disclosure. We've all seen this. We've all heard it. Here it is. We're disclosing this. All right. Moving on to our next slide is our learning objectives for today.
Okay, so our learning objectives. So after today's presentation, we hope that you can first identify the key goals of FFPSA, which is the Family First Prevention Services Act, and the Qualified Individual Assessment for QRTP admission. We also plan to demonstrate how the CANs can be used to make level of care decisions. Of course, hypothesize the strongest potential relationships between risk behaviors and other needs and strengths. And then finally, to discuss potential residential treatment implications based on findings of relationships between risk behaviors and other needs and strengths. So a little bit about Maximus. So I'm going to go over some of the groundwork for our presentation today. I will mention, pay attention because we will be playing a game midway through our presentation with prizes. Not chocolate, but prizes. So, so a little bit about Maximus and what we do. So Maximus is a national leader in providing conflict-free assessment services. So since 1975, we've partnered with different federal and state agencies to meet legislative mandates and operational improvements. So we've performed child welfare, compliance, and management projects, health service and Medicaid access services, and specific to the Clinical Services Division, which the four of us work within, mental health and intellectual disability assessment services in 14 different states. So we've been involved, Maximus, in the Clinical Services Division with FFPSA since its inception, really bringing expertise in child welfare and clinical assessment operations to our state partners. So we really take pride in setting those industry standards for delivering high quality, innovative, and value-driven solutions through comprehensive project management services, and trusted processes, configurable information systems, and specialized tools for delivering clinical assessments and outcomes. So we're currently conducting the CANs for youth in different residential states, including Indiana, Michigan, New Hampshire, North Dakota, as well as the Illinois Medicaid Comprehensive Assessment for Needs and Strengths, or the IM CANs.
Really quick, do we have anyone here from those states? Awesome.
Okay, perfect. So, just out of curiosity, how many are you how many are familiar with FFPSA? Okay, so perfect. All right. Well, for those of you that are not familiar with it, it was signed into law in February of 2018 as part of the Bipartisan Budget Act. So it's considered the most comprehensive source of child welfare legislative reform in over a decade, and it was acted to turn the focus of child welfare services toward keeping children safely with their families whenever possible. So to support the number of children who can remain safely in family settings, the following priorities were really put into place. So really upfront prevention efforts are prioritized by allowing federal reimbursement for mental health services, substance abuse treatment, and parenting skills training. Also, placements in family settings are maximized by focusing on family reunification and reducing unnecessary delays in in-home placements. And then lastly, states are incentivized to reduce placement of children in group or institutional settings. So they do this by limiting federal reimbursement for non-family settings for longer than 2 weeks. To those facilities that meet licensing standards for qualified residential treatment programs, also known as QRTPs. So really the only exception to those requirements include being identified as a group setting that specializes in services for pregnant or postpartum youth, supervised independent living programs for youth over the age of 18, or programs that provide services to youth who are survivors or risk of human trafficking. So for the purpose of this presentation, we're going to focus on QRTPs. So what is a QRTP? It's a Qualified Residential Treatment Program. So as of October 1st, 2019, facilities previously known as child care institutions are designed to serve children with specific treatment needs who require short-term placement out of their home. So there are a few requirements that the federal government put into place for QRTPs specifically. So they must be accredited. They must have a trauma-informed care model to address needs of children with serious emotional or behavioral disturbances. They must require to have licensed nursing staff. They must facilitate family participation and provide aftercare services for up to 6 months post-discharge. So FFPSA also requires a conflict-free independent assessment by a qualified individual for any children that are being referred for a QRTP admission. So as I mentioned, Maximus completes those assessments in 4 different states. So the assessment itself must be completed prior to or at least 30 days post-admission in order for the state to be eligible for federal reimbursement. So in order to be qualified in order to be considered a qualified individual, the assessor must meet the definition as a trained professional or a licensed clinician who's not an employee of the state or an agency that is affiliated with any type of placements within the state. And that's really to ensure that the assessment itself remains conflict-free. So the QI must assess the child's strengths and needs using an age-appropriate, evidence-based, validated functional assessment tool to support making determinations about the least restrictive setting that is most appropriate to meet the child's needs. So the decision must be made on treatment needs and not due to any type of shortage of family or foster homes. And then the assessment goes through a court review process within 60 days of admission to take that QI assessment into consideration. So as many of you know, the CANS has been widely accepted by multiple states in order to complete QRTP assessments. So it's also important to understand just the overall general workflow that Maximus completes in order to be the QI. So Maximus receives that referral from our specific state. We then assign it out to a field-based assessor in those specific states. They go ahead and complete interviews and as well as complete the CANS. They return it to Maximus for the quality improvement process. And then we complete the final determination report. Some of our states, we actually even e-file into the court system, and others, those reports just go back to the state and they follow that court review process. All right, so really this process, and we work with those 4 different states to really ensure that we're meeting their individual needs as state partners, but then also really driving those state-specific agendas within the child welfare system.
All right. So we've heard the word algorithm used a lot this week, so I don't think that's necessarily anything that's new to a lot of this group. But I do want to talk about how we use the CANS as a QRTP level of care tool. What is the reason for an algorithm to start with? What we know is that human bias can really impair judgment. We use the word clinical judgment a lot, but one thing that I've learned in working with probably 10 states or so in the last few years, clinical judgment looks very different for everyone. Even when you think it's clear as day, you can bring a circumstance to a discussion and just find out that someone else is interpreting a scenario entirely differently than you are. So that's really where something like an algorithm really comes into play. And the way that the CANS works, it can be tied to logical functional pathways and levels of care. So a lot of other assessment tools work more like there's kind of a composite score and there's like cutoff scores. You know, if you score an 18, you're at this level of care, that type of thing. The CANS doesn't really work that way. It actually allows for, I think, a little bit more flexibility and a little bit more complexity of needs, because the way that it works, you can essentially have different levels of acuity based on different levels of needs and the severity of the needs. So it's essentially you can have combinations of needs at a certain level of severity that can mean you're likely appropriate for this level of care. Now, of course, as we know, we can certainly override those, and there are times that I think even within those algorithms, I'm very personally passionate about just documenting those discussions and documenting decision points and documenting areas that we want to continue to monitor. So really, when you're looking at creating an algorithm, and I will say, when I say creating, I will give Dr. Lyons a shout out and April a shout out. A lot of the states that we've worked with, they've really come in with a draft algorithm. They've worked with the state. They've had some conversations with them. Really, the way that an algorithm often works in this world is just being realistic. Although we don't want to make decisions based on the shortage of foster homes, we do have to look at the level of community supports that a state has, right? So essentially, if a state has a high level of community supports, you might be able to actually raise that bar slightly for admission criteria. Whereas if it's a state where, you know, there aren't a lot of community supports available, you may have to kind of think about lowering it. But that can actually change over time. You know, it's really, you can think about what is your goal? What do you want to have happen? We know that the goal of FFPSA is to have kids in family settings whenever it's possible. So we are always looking at guiding things in the direction of that goal. I mentioned our first project in 2019. I will give them credit. North Dakota, they've made changes. We've consistently refined and said, okay, we've got more foster homes now. We've got more community services. We're ready to raise it. We recently actually did a study where we looked at some of the kids that we had said were community appropriate, did not need to be in a QRTP, and we found that 80% of those kids were maintaining in a family setting. So that's even with us kind of raising the bar as we've gone along. So we're seeing some good work happen. I know with Michigan, they were our second one that we've implemented. We're having some discussions there about adjusting it and saying, I think we're really ready. I think we've really put some community supports in place that are moving us to the right place. But we also have to think about safety. Some really, really smart words that I heard Dr. Lyons say once throughout my implementation experience was, you have to think about what you want to do aspirationally and balance it with what you can do safely. And so that's always something that we have in mind as we're working through this. So generally for residential care, what an algorithm is going to look like for that is a combination of behavioral and emotional needs and risk behaviors. That makes sense, right? You know, if they're not having these risk behaviors, they can generally be safely in a community setting. So we definitely look at those other needs. Those other needs and strengths are super important for us in terms of care planning, in terms of setting goals and things like that. But in terms of our actual decisions that we're making, those tend to be the domains that we're focusing on the most heavily. I'll also talk about testing an algorithm, and this is kind of an area where I get a little nerdy. I mentioned that I really, really enjoy the data. So testing an algorithm, I think, is super important and probably one of the most fun things about my job that I've experienced over the last few years. So a few ways that we've done that. I'll use North Dakota as an example. They came to us and were already using the CANs with their therapeutic foster care. They were using it with PRTF kids. They were using it with kids in the juvenile justice population. So we had CAN scores that already existed in different levels of care in their state, and we were able to really look at some analysis of that and where are the trends and what is a realistic, you know, way that we might want to think about how a cutoff could be for this. For Michigan, they weren't using the CANs. They are actually, I think we may have someone here in Michigan, I'm not sure, but Michigan I know is actually looking at implementing CAN statewide in child welfare very soon. So they haven't been using it. So there we actually ended up working with the state to take case records of kids that were in their CCIs, which became QRTPs, and we scored CANs on them and looked at that analysis and used it to kind of adjust things a bit. New Hampshire was our third one, or actually no, they're our fourth one. So because we had Indiana in there too. New Hampshire, we did some fun stuff where at that point we had hundreds of CAN scores for kids that were in this population. So we were able to actually take New Hampshire's and just test it. We just took a random sample of hundreds of CAN scores from other states and said, you know, this is kind of your percentage that you're going to end up with in each level of care that you have if we leave it as it is. Is that what you're going for? Or do we need to adjust it? And we had some really good conversations around that. So again, I could nerd out about this all day, but I don't want to take up the whole time. So I'm going to hand it over to Chelsea.
So Sorry, I keep walking back and forth. So actually earlier in the conference yesterday, we were actually sitting at a table with Brandon Howlett, who is with TCOM, and he was discussing when he's doing consultation with agencies or different entities, he's asking them what kind of industry do they work in. And as he's getting the answers, he's like, actually, we live in a transformative in a transformative industry. So in regards to that, with Maximus, we've definitely taken that on in regards to looking at challenges and then partnering to find solutions. So we work closely with our states to say, hey, what are the needs here? And then we have meaningful interactions to be able to alleviate some of these items by creating solutions. So some of the things that we've seen, which of course you've probably seen in your communities as well, availability of foster families and community resources. So as we talked about FFPSA, availability of foster parents is not necessarily a reason for a referral to a QRTP, but however, it is a part of it because as we look at step-down planning, as we look at meeting the needs of kids, we have to take that into account when we're completing the CANs and identifying outcomes. Lengthy admissions and readmissions. So once again, that feeds into availability of step-down programs, availability of residential beds for youth who are ready to transition or who may need to transition up. Access to aftercare post-discharge. Aftercare is part of FFPSA, but of course we are still in the first year. So I think just getting used to that consistency of programming and what that looks like on the ground. Our hope is that, as it moves forward, we'll be able to see some change with that. Temporary diversion programs, links back to beds. We see a good number of kids who are in short-term residential or maybe in a shelter where we have to assess and try to figure out not try to figure out what we use items, but we look at the level of care and see what's appropriate for them. Educational gaps, such as credits received in the QRTP, especially for our older youth who are in high school, that plays a big piece as well because if they're not getting it, that limits where they can go in the community, and once again, trying to bridge that gap as well. The juvenile justice population, do they go to detention or do they go to residential? And I feel like that's an ongoing conversation in many spaces. And so a lot of the data that you'll see moving forward will kind of touch on these parts and you'll be able to see, and we'll talk about maybe implications for treatment moving forward.
All right, so I'm gonna just talk a little bit about, we're gonna start by talking about just, what are the prevalence of the needs and strengths in the youth that we're seeing? And then we're gonna dig a little bit into the data. We'll kind of play with that a little bit. But I wanna first just talk with you guys a little bit about what our sample size is for what we use for this presentation today. All right, so our participants were children and youth ages 8 to 21 who were referred for admission for QRTP in a state where we're completing the qualified individual assessment. Most states don't go up to 21. New Hampshire does. I will briefly just say that New Hampshire did expand their process, so we are not just doing them for QRTP. We're doing them for every residential type of program they have, and they actually, so one of them is one of the exceptions that Natalie referred to earlier, which is those independent supervised living. So we do get kids 18 to 21 for that particular program in New Hampshire, so that's why it goes up to that age. We did not include any youth that had multiple assessments. Chelsea just referenced readmissions. We unfortunately do have kids that discharge and then we see them again. We also have certain contracts that we work with that have already scheduled reassessments. So I think we'll continue to just see some of these qualified individual federal requirements be refined or get more guidance as time goes on. But essentially right now, that initial assessment, they're good for a while. There are some initial or some additional limitations for kids that are under 13 that stay in a QRTP for up to 6 months, and for kids that are older than 13 or up that are there for longer than that, for I think it's 12 months or 18 non-consecutive. But it really that's been a thing to me that's just fascinating. Is it's like, okay, you do this assessment and you're in residential now until that second layer of approval. So we do have states where we have a second reassessment at a scheduled interval to see if they continue to meet eligibility. But for the purposes of this, we did not include that. That resulted in a sample size from our 4 states of 1,184 youth that we're looking at today. All right, so I don't want to bombard you with data slides today, so you will find a few times today that I'll point to our data slide, but then I'll say the rest of these, if you want to peruse them, I will strongly encourage you guys to take a look at the slides that are attached in the app, because this may be small for some of you to read anyway. You can probably see it pretty well on your screen in the app, but we do have additional slides in the appendix. Like I said, I don't want to just bombard you with data slides today, so we'll just kind of touch briefly on them. I'll talk about a few other key points. So I am going to just highlight here, we're primarily focusing on our risk behaviors, so I just want to talk about a little bit of those. You'll see danger to others in terms of risk behaviors really appears to be the most common reason that youth are referred for residential care. They're with a foster parent. That foster parent doesn't feel safe anymore. They can't stay with me. They have to go. Those types of things. We see that quite a bit. So that makes up 730 youth, or about 62% of the kids that we're seeing. You can see runaway is our second highest. That one is present about 47% of the time. I will say we've probably had more discussion with our states around runaway than a lot of these other needs, just because I think that's one where you really have to dig into where are they running from? Are they always running from the same place? Are they only running from treatment facilities? What does running away look like? How long are they gone? Do they return on their own? Are they engaging in unsafe behaviors when they run? I know North Dakota specifically has had some real concerns with some of their programs are very close to some major highways that are kind of known for being trafficking routes. And so when they have kids that run from their facilities and go hitchhiking, that's a that's a real concern, a safety concern there. So just a lot of discussions that we've had ongoing around that particular need. So I will just give you guys some highlights. I'm going to leave it on this slide. Again, you're welcome to peruse the appendix. I just want to point out a few other things that we found that I think were really interesting. Decision making was our highest prevalent item. And I will say, when I say prevalence, this means anything that scored a 2 or a 3, basically. And then for our strengths, it's anything that scored a 0 or 1. So again, decision making, the highest prevalence, so 93% of the time, the youth that we're seeing are scored 2 or 3 for decision making. Legal, super high too, 48%. So I think that kind of harkens to Chelsea mentioned earlier. That's just an ongoing conversation of treatment versus detention, and how does that work, and how do we navigate this? And they want us to recommend detention. We can't recommend detention, things of that nature. So family functioning, present 77% of the time. That certainly makes sense. These are kids that primarily we're seeing because they're in foster care. So there's certainly some family functioning needs there. Behavioral and emotional needs, impulsivity, hyperactivity, present 83% of the time. I think that could go hand in hand with decision making. The decision making is the impulsive thought process, and the impulsivity, hyperactivity is the impulsivity of their actions. So that one's high too. Adjustment to trauma, 71% of the time. Kids have a 2 or 3. So they were on to something with FFPSA when they said, you got to have a trauma-informed model of care, because the kids that are being referred to this, absolutely having adjustment to trauma needs. Conduct, that's a tricky one. So conduct is rated 2 or 3, 49% of the time with kids that we're assessing. I will note, I was in a breakout session yesterday about waivers, which was great, and someone mentioned kids with conduct disorder not being eligible for EPSDT services because they didn't believe it's a condition that could be ameliorated, that is disheartening to me, but it's also like, how do you treat it? And we all know it is hard to treat, right? But we're seeing it at a high prevalence. I will point out our caregivers' needs. That's a tricky one for us because, as you know, it's rated as who is their primary caregiver right now, or who is the caregiver identified in their permanency plan. So kids that we see are often at a very, very vulnerable juncture in their life. They may not have a permanency plan when we assess them, because I mentioned earlier, they were with a foster family. That foster family said, I'm afraid of them now. They hit me, they hurt me. I don't want them to stay here. So sometimes at the time we're doing our assessment, they don't know yet. They don't know where they're going. And so I think because of that, we may have kind of a skewed set of data in that, just because there's a 0 for caregiver needs for a lot of those kids. There's a quick question, yeah.
When you're talking about qualified individuals and that they're doing the assessment, are the results of that assessment being shared with the QRTPs? Because QRTPs are also doing that, at least in Illinois, the IM cans.
Yes.
And then making treatment plans off of the IM cans that's completed on site. And so I'm just curious if there's collaboration there, because it feels like that's a good tool to assess whether there's, fidelity of the implementation of the
Yes,
cans.
no, absolutely. So in some states, yes. I think in probably every state that we're working with, they get a copy. It's a little tricky for us because if we don't have a release, we can't release it directly to them. But we strongly, we don't just encourage. We say, you need to give it to the QRTP. What's the point of us doing this if we're not handing it to the next person?
For North Dakota.
So, yeah.
So for North Dakota specifically, we do send the assessment directly to the QRTP if the child is placed at the QRTP at the time of assessment.
Cool.
So it goes directly to the QRTP.
Very cool.
So when you say assessment, you're talking about the CAMS tool?
Yeah, and we do have, yes, but we do, so we actually have, we do send them the scores, but we create as part of our process a determination report. So it talks through not just what the scores were, but why. They were scored that way. It also gives some background on why were they referred to us. There's some other things that are federally required as part of the determination report. We have to set short-term and long-term goals. Those are based off the CANS scores. The CANS is set up in a lovely way for short and long-term goals, because your short-term goals are your dangerous, disabling, you need to stabilize them. Your longer-term goals might be some of those affecting functional needs. So we are definitely going to leave time for questions at the end. I'm glad you guys have questions. I want to make sure that we get to some data for you guys, though. Really, really briefly, I want to talk about strengths, too. 4% of our kids have a 0 or 1 for community life, and that is very sad to me. I will also point out only 10% have a strength or natural supports. I think what we see is these kids have a ton of paid supports, a ton of professional supports, as we know, since we have to talk to every permanency team member. Some kids come with 10 people that we have to talk to as part of an assessment, but they don't have a lot of natural supports. On a positive note, 75% of them have a 0 or 1 for talents and interests. But I will point out, as many of you probably know, in a residential setting, do you get to always do the things that you like to do or have access to your stuff or have free time? Not so much. So definitely something we want to keep thinking about. All right, I'm going to hand it over to Christy to talk about our analysis.
Okay, if you can go ahead and move to
Sure.
the next slide. So here are research questions. We approached the data, we had some idea of what we thought might be there, but we had some very specific questions. Our very first one had to do with risk behaviors. So when a risk behavior is there, what needs are related to it? What else are we seeing? What patterns are there? We were also looking for strengths. So we looked at both, and I'm going to quickly go through some of this because I want to make sure that we can get to what we found. But essentially, we found that the strengths weren't nearly as connected as we were thinking they might be, but we definitely did find some interesting pieces with our needs. All right, so let me give you a real quick explanation of what we did. It's called grounded theory because we're working in this day in and day out. So we're seeing this from the point of view of being inside the work. We did an inductive, iterative, sort of qualitative analysis to begin with. So we looked at what we had. We had 1,184 CANS assessments, each of them with multiple needs and strengths and other rankings. We took those, looking for 2s and 3s for the needs and the risk behaviors, and 0s and 1s for the strengths, and we started looking at the patterns. We looked at them based on the subset of the kids who had 2s or 3s for a particular item versus everybody else, and then versus the smaller group or the subset that they were in. We ended up with patterns and themes along that domain level, which is the macro level. We also had them on the micro level for each item. Then what we did was came in with a little bit more quantitative look at things. We ran a chi-square independence test, which will also get you correlations, specifically polychoric correlations. But
For
it'll
you
give
data
you
nerds out there.
It'll give you correlation scores. And so we decided to look at correlations that were at least 0.25 and above. And that's where we are going to get to this next piece. Lots of these are in your appendix if you want to see more of these. But we ended up at first with this chi-square independence test. The darker colors mean a stronger relationship. Okay, so in this particular one, I don't want to lead you astray. Let me make sure I'm going to say this right. Dark green is a positive correlation or a positive relationship. Dark pink or almost red, those are negative relationships. And so when we started, we thought, we're really going to find a lot of strengths, or at least we were hopeful that we were going to find a lot of strengths that we could, like, maybe we could build on those and help kids or support kids who have particular needs. Unfortunately, what we found based on a lot of this work is that the strengths weren't really correlated strongly. Either way, negative or positive, there weren't correlations out there that were statistically significant. The ones sort of things that we found, strengths were positively related to each other. So if a kid had one strength, it probably coordinated with another strength, and there were pockets of strengths that worked together. There was one that we found that was very interesting. So strength and risk behavior. So danger to others was correlated to interpersonal skills. And so the trend is it was a positive correlation. So if a kid had strong interpersonal skills, I'm sorry, I think I just said it was a strong positive, and it was actually, is it strong? Okay.
Yep.
Then if they had a risk of danger to others, they probably had a low interpersonal skill. But if they had high interpersonal skills, which include empathy, their danger to others was much lower. And so this was the only relationship that we really found between a strength and a risk behavior.
And I'll just do it. That one's a positive one because, as you guys know, they're kind of flipped in how they're scored. So essentially, if you have a 0 for interpersonal strengths, meaning you're great at making personal connections with others, you're probably also going to have a 0 for danger to others, right? So makes sense.
Okay, I'm gonna talk quick because this is the fun part, and I know we only have like 20 minutes left. So, I'm a literacy educator. I love words. I'm gonna maybe teach some of you a new word. It's called wonk. It's not related to the word wonky. This is a wonk. Anybody know what this word is? I know it's on the. Did you know before you walked in? Oh, I see. Smarty pants.
I did not.
Smarty pants. I did not either. So a wonk is someone who takes an enthusiastic or excessive interest in the specialized details of a particular subject or field. Normally, it's got to do with political policy, but in this case, we're going to talk about QRTP and cans. All right. So I hope there's some wonks in the audience who are willing to answer some questions. Are we ready?
Yes.
Who wants to be a wonko-air? Mainly because, hey, I do not have $1 million. I'm sure we all would love some. I don't have that. Our budget is much lower. But we are going to
value-based contracting.
Value-based, right.
So.
We are, however, going to follow the rules of Who Wants to Be a Millionaire. So please do remember, these are multiple choice questions. You can phone a friend, or you can poll the audience, all right? So these low sort of anxiety here, folks. Okay, all right, so just raise your hand if you're willing to answer the first question. The first question is, what tool is Maximus using to assess the strengths and needs of referred youth? I see this hand first. Yes, ma'am. Hold on, I'm coming. Which one? Yeah. Which answer is it? What are we using?
The cans.
We're using the cans. That is correct. Woo! Prizes.
There are real prizes.
They're prizes.
They're not chocolate, but they're awesome.
Okay. Question number 2. Maximus provides conflict-free assessments for youth in, I see blue shirt, I'm coming to you. All of the above is correct. I guess I don't have to run all the way back there. It is Michigan, New Hampshire, Indiana, North Dakota, and
all of the
that
above.
Is all the above. All right. This next one. I see you. Let me read. According to the Family First Prevention Services Act, Maximus assessors are qualified individuals because 2, they are trained profession or licensed clinicians who are not employees of the state agency or connected to any placement setting where the state agency may place children. And as a teacher, I realize I gave away the answer because that is the longest one up there. If you're a good test taker, it's the one you pick. All right. Next question. How many participants ranging in age from 8 to 21 did we have? Yes, ma'am. Number 2, it was 1,184. There's a bonus question. This is not multiple choice. which makes it so much harder. Whoa! Okay, somebody up front. Somebody's going to have to figure out.
Oh, yeah.
Yeah.
Family First Preservation Preventative Services Act.
There
Okay,
you go.
I think they helped each other. We should give them both a
give them
prize.
both.
It was like a group effort.
extras.
Let's do it. Okay. All right. So I will turn it back over. That was our very brief game. Thanks for
Let's
the wonks.
just go super, super quick. Do you guys kind of have, like, what do you think potentially correlates with danger to others? Okay. Yeah, I mean, I think we all came into this like, I'm not sure, but in the interest of time, we will show you.
Hold on.
I thought it was interesting in that list, when I think of when people rate and things like that, danger to others seems to be more general than some of the others that had some very specific
Sure.
qualifiers.
Sure.
In order to rate those items. So
I agree with you.
Right.
That you are speaking my language here because we have definitely had some conversations with our states. Danger to others is probably where we have the most gray area discussion on twos. Because you can have a 2 for danger to others if you're having verbal aggression. You can have a 2 of danger to others if you're harming someone on a daily basis. So, yeah,
So
definitely.
I was going to ask, because you had said, I think early on, that you, I mean, you like reading the supporting information and that. And obviously
Yes.
that's harder to capture in
Yes.
bar
So
graph.
I will give you guys a little secret. Don't share this with everyone, industry tools. What's the last time it happened and what did it look like?
So then that way you make, does that then?
Yes, that helps distinguish it. What did it look like? So not just he gets angry. What does it look like?
What level?
The
Yes.
actions. Or
Oh, he's definitely dangerous to others. When's the last time he was danger to others? What did it look like? Tell me what happened. Like, I want the facts. Just the facts, ma'am. It's kind of, that's my whole thing. Yes, all of that. Okay, so Christy did a great job of walking through. Basically what we did is we looked at when danger to others is a 2 or a 3, what else is also a 2 or a 3? We just played with it. And really what you're going to see here, so anything in purple, that's going to be what's also present when danger to others is present. The green bar is the presence overall. So our theory was anywhere there's a large disparity, there might be a relationship here. So for example, anger control, this one makes sense. It's kind of a no-brainer, right? So when danger to others is present, anger control is present 90% of the time. But anger control is only present 70% of the time in our overall sample. So that starts to tell us probably anger control and danger to others have a relationship. Again, that one's not necessarily groundbreaking, but that gives you an idea of what we're looking at. So what we have here was our top 7 disparities. So this is the largest disparity down to the number 7 disparity. And then we've basically applied that qualitative analysis, which we'll show you on the next slide. So basically, did our qualitative validate what our, did our quantitative validate what our qualitative found? So, all right. Me and this clicker. Okay. So our 0.25, the line that's here, this is our statistical significant. If it hits this line, it is. So what we did basically on each of these slides, we took the 7 that you saw on the prior slide and then looked at, on those heat maps, what was the correlation coefficient that was there. And then if we found anything else that was over 0.25, you'll see it on these slides too. Again, all of these are if you don't see a risk behavior that's what we're going to walk through today, it will be in the appendix. I did not want to bombard you guys with tons of data slides. All right. Anger control, we validated it. Social functioning, we validated it. Conduct, we validated it. Oppositional, school behavior, impulsivity, we validated. Attachment difficulties, you can see is 0.23, not quite. So we want to keep an eye on that one. I want to make sure that I say this is not predictive. We're not at that stage yet. We don't have a large enough sample size at this point. But it's exploratory. It's got us thinking. It's got us thinking about what are we seeing and what do we want to do with this? Some additional ones we did find: intentional misbehavior and decision making. Also, we found a relationship. You mentioned fire setting. Fire setting was very low prevalence overall. We only had 24 kids that had that. So I was kind of with you, but I think that impacted it. All right. We did have, I will just very, very briefly, because some of our slides here were just smaller. So I did group sexual aggression kind of with danger to others. I grouped fire setting with danger to others because we found some similar trends. So really, really quickly, just a couple of relationships that we validated with sexual aggression, sexual development. That was the only thing that correlated. And I think it was because of our sample size. We had 166 youth that had a 2 or 3 for sexual aggression. So I think we just didn't have enough of a sample size to really validate it. Fire setting, as I mentioned, only 24 youth. I will point out, though, anger control and conduct did have a relationship with fire setting. So that makes sense, right? When we think of conduct disorder, I feel like almost fire setting is the thing that can come to mind with it. So it makes some sense. I am going to hand it to Chelsea. Why do we care? We're all about transformation, right? So why do we care about this data?
And so like Emily mentioned, we use CANs as part of a bigger assessment. So as we're looking at, for example, danger to others and how that intersects with other items in the CANs, it helps look at treatment and be able to, look at long short-term goals for youth in residential care, even if they remain in the community. So danger to others, anger, like she said, anger control was the biggest one. While we mostly look at safety, and which is important, we also have to look at underlying anger, underlying drivers to anger, having kids, being able to understand their emotions, their feelings, kind of thinking about that cognitive triangle of, thoughts, feelings, behavior, to be able to move towards maybe at reassessment, getting a lower score. Social and interpersonal skills, a focus on that. Not only modeling, positive behaviors and positive interactions, but having them, promoting them to be able to do it. Like, how do you increase empathy in some of our youth that we're seeing? How do you get them to understand? A lot of times they're coming from a lot of adversarial relationships, so they have to be able to see and practice like that healthy relationship building. And then something that, in looking at the data that we thought, we could continue to monitor was the impact of attachment. As these youth are coming out of homes that maybe involve a child welfare, what is the impact of that early attachment and what does it look like moving forward?
Cool. In the interest of time, I'm just going to skip to our data slides to make sure we have some time for it. I did group runaway, delinquent behavior, recklessness, and sexual exploitation. Lots of similar themes that we found with those 4 as well. They actually were quite often strong relationships with each other also. So I will point out just a couple of trends that we saw there. Substance use. This is when substance use entered the chat. We really started seeing that a lot. School-related needs. Really some interesting things that we found here, which, as we talked about, we all know school can be an afterthought, realistically, in residential care. And we started to see some things like recreational needs as well. We saw a few caregiver needs, but again, I just want to remind you guys, these caregiver needs, I think, are a bit skewed just because we really do have more zeros than I think is probably actually representative of what the actual impact on their lives are, of who maybe their primary caregiver was before we saw them. All right, so runaway, you could see substance use, recklessness, school attendance, delinquent behavior, oppositional, and sexual exploitation. So overall, we're primarily validating some of those things that we thought when we were doing some exploration. Delinquent behavior, you'll see some similar things. Again, conduct, substance use, runaway, school attendance. We do start to see some caregiver needs. So even though we think they're lower than they may be actually impacting them, we do start to see some caregiver needs here. So even with them being kind of lower than anticipated, there's still some relationships here. Yep.
Especially in New Hampshire, up to 21 years old, and you have that 18 to 21-year-old bracket where they're their own, they're living on their own or something like that?
So that's a small group. I mentioned earlier that it's really because at the time that we assess a lot of kids, they don't have a permanency plan. They're kind of at a juncture. They're at a transitional stage at the time we see them, and they may not have a caregiver identified. So in the manual, and we've talked to April about it as well, 0. So that's why you're seeing it skewed a little bit. You can see delinquent behavior and legal, our strongest one yet. that one makes a lot of sense. Conduct, substance use, runaway, school attendance, which I thought was super interesting. Just school attendance and delinquent behavior. Just, I don't know, there's a lot going on there. Supervision, again, was not quite at the 0.25, but considering that it's probably lower because of the way that our methodology is, that makes sense. I'm not going to spend too much time on it, just really, really similarly, you're going to see some similar themes with recklessness and similar validations. So Chelsea's going to again talk about, so what are the treatment implications for these needs?
Sure. So like Emily mentioned, in a lot of those we saw that substance use was prevalent in regards to like the runaway, delinquent behavior, recklessness. So once again, creating goals that help kids or guide kids to be able to be linked with substance use specific treatment. And we know a lot of times in residential that may not happen, but we want to highlight, especially when we're seeing in the cans in that manner. Also, healthy recreational activities. I think a lot of times, well, not I think I've seen, a lot of times with youth who exhibit oppositional behavior, conduct behavior, a lot of times the default is to be punitive. Take this away, take that away, restrict them, take away points, even in some programs. But it's like, or give them into pro-social activities. They're with positive peers. They're engaged. How many times you hear kids say, I'm bored? You know what I mean? Like leave them to their own devices and you see what happens. So keeping them engaged in healthy recreational activities, school engagement. Like she said, the data shows like the school is a big piece, and we want to move towards, once again, being collaborative. So how do we bring the school at the table? I know in New Hampshire, the Bureau of Children's Behavioral Health basically said like we need the school voice in these assessments. Like we want them to be involved because that's missing a huge chunk. Like Christy said, kids are there 8 hours a day, so you're missing a huge piece of what this child's day looks like. And then, of course, as we always look at safety, making sure supervision is involved. Are we engaging that parent, even when the kid's in residential? Are we, ensuring that safety planning is in place to be able to address those, risk behaviors?
Yeah, it's fascinating to see that, again, even though it wasn't quite validated where we're at, like it's fascinating to see that some of our kids with the highest risk behaviors are getting the least amount of supervision. So, all right. We're going to jump on into suicide risk and self-injurious behavior. We did pair those two together. They had a strong relationship with each other. Of course, depression, anxiety, that's probably not a surprise. Adjustment to trauma, also probably not a surprise with this one. I will point out that although we have a relatively low number of kids that score 2 or 3 for psychosis, that stands out here. And will stand out even more on the next slide. There is a 0.39 correlation that we found between psychosis and suicide risk. We think that's primarily because, as the kids that we're assessing have not reached that age where they're getting diagnoses of schizophrenia, but we do think they have some command hallucinations, is probably the main reason that that's scored the way that it is. I will very briefly note that we do have a fairly large tribal population in North Dakota and in Michigan. And I know that cultural sensitivity is always something we want to talk about with that. I don't think that's the case here. I really do think that that's being rated with our assessors because of command hallucinations. Again, really high relationship between suicide risk and non-suicidal self-injurious behavior and depression and anxiety and adjustment to trauma. And then our self-injurious behavior relationships look very similar. And they also look very similar here. Again, I'll point out psychosis 0.33 with that one. That one, I have to say, of everything we found, I might have been the most fascinated by that one. The danger to others and social connection was interesting to me, and then this one, I was just like, I would not have anticipated that one. So that was kind of cool.
And so for suicide risk and self-injurious behavior, treating symptoms of depression and anxiety. So like we saw the data beforehand, but once again, as we've been stating, like what's underlying that behavior, a lot of focus when we're doing these assessments and doing interviews is what is being seen, right? Like what behavior is seen, but then kind of going in deeper a little bit with that youth and getting the drivers to those behaviors. And then once again, addressing trauma. Adjustment to trauma is a big module in the CAN. So once again, using that in treatment planning. If that's a driver to those behaviors, making sure we're addressing that. And then, of course, in the neuropsychosis or really any of these behaviors, safety planning, safety, and make sure we're doing that, but also being collaborative. Are we talking to the psychiatrist? Are they, involved? Is the family involved with the treatment plan? Things of that nature, just to get a better idea of what's going on and how to best create some interventions for it. And so, of course, list, but you have this in your slides as well. Just some evidence-based practices that we've seen some of our states use that are well supported in addressing some of these behaviors. So looking at disruptive behaviors, your brief strategic family therapy, MST. I know New Hampshire just rolled out MST there. Trauma and attachment, EDMDR, trauma-focused CBT is, a huge one. But I also think, when you're talking about trauma and attachment, looking at those alternative trauma-informed therapies are really helpful because some kids just don't take to like one specific, model. And then also with substance use, once again, the brief strategic family therapy, MST, are good with interventions and kind of coming in hot with that. And then a multi-symptom approach. So looking at match ADCC just to kind of treat like the whole child, in regards to multiple symptoms instead of just looking at one thing.
I will very quickly say, I heard someone say this week that I'm a soap factory over here. I have so many soap boxes, and I love that, and I'm stealing it because it was cute. A big soap box of mine, these kids cannot build rapport for months. They need to do evidence-based treatment. That's what's going to get them back into families where they belong. So that's just something that I'm preaching it all day long over here. So this is us.
Questions?
Yeah.
We have 2 minutes.
Thank you.
Coming back.
Oh, they should have given you a longer slot.
Thank you. I appreciate that.
We implemented
Next year. Pass that on.
We implemented just a year ago, so we were kind of a late implementer of the QI practice, but we didn't get a lot of guidance from the state, and so I utilized some of Maximus's resources, and I just appreciated you guys for putting all that online. They were great.
Thank you.
One thing that I noticed, and I can't remember if it was North Dakota or South Dakota, is that some of the research that you guys had showed that the state is actually placing fewer children now
They are.
with that. And I'm wondering if you're finding that throughout or if that just happened to be unique to that state.
Yeah, so I have a couple of thoughts. North Dakota is definitely doing a really good job there. I love their state officers. They are just some of the most passionate people I've ever worked with. But I think we're seeing it in Indiana. I think because when we kind of started this work, they had a lot of projections, and I know we're finding we're lower kind of than anticipated in Indiana. So I think they are seeing it a bit there. I don't know if you guys could speak to New Hampshire, like are they?
Yeah, so I think for New Hampshire, what we're seeing is, I can't necessarily say we're placing less kids, but more outcomes are leaning towards like that QRTP level of care. So what we're seeing is that when they're making the referral is more spot on, or what's going on with the kid is more spot on, leaving the residential versus.
Yeah.
And again, then we had like family, PRTF, like, all those.
Yes,
It
yes.
was just like, we have these cute kids that need to go somewhere, but as we continue to have our meetings with the state, talk with stakeholders, and just, workers and referral sources working with the program, they get a better idea of what that QRTP kid looks like. And plus, with them building out like more community resources, they've been able to then intervene early. So that way they avoid a residential.
That's a really good point, Chelsea. I think there is definitely a natural weed out process that happens over time. And I think we've definitely seen that. We are right at time, but if anyone else has a question, we're hanging out for a minute, for sure. So, thank you.